study we might like to talk about today, which is the use of a pilot of yoga, personalised yoga, compared to group exercise or group fitness training. So it was a very small pilot. We were just dealing with a single hospital, the Royal Prince Alfred Hospital in Sydney. That's what you see here. 11 were randomised to personalised yoga, 10 to group exercise. We had one early withdrawal on the yoga side for medical reasons, and 2 on the group exercise side for work and study reasons predominantly. This sample was disproportionately female. It was 76% female, but it was actually quite proportionately represented in terms of the type of junior doctor roles that were involved. We had registrars, interns and residents, predominantly registrars. Interventions reduced burnout, and I think this is something that that was really nice to see in the quantitative data. We only dealt with an 8-week intervention here, so we're really only dealing with 8 hours of intervention. Now, on the yoga arm, we did also offer a 4-hour optional retreat on a weekend that half of the participants attended, or 6 of the participants attended. So there was a little bit more offered in the yoga arm, but we are really only dealing with 8 weeks here. So the results are reflecting that data. And this is only, I remind you, arm 1, so the 10 and 8 that completed arm 1. So we saw compassion satisfaction increase within groups, certainly within personalised yoga, but quite importantly on the Maslach burnout inventory, which is a common measure of burnout, we saw a big shift in depersonalisation in particular. And now we might expect that of a personalised intervention, that depersonalisation would be addressed, but I think we were also seeing a little bit of interaction here with the type of intervention. So the yoga intervention certainly incorporated physical postures, but it also incorporated breath, it incorporated meditation, it also incorporated the potential for that one-on-one therapeutic alliance to build up with the individual, and some of that came out in the qualitative data separately. And we also saw here, as you can see, indicated by the arrows, that personal accomplishment also increased in both groups, which was quite good. In terms of the trauma-specific outcomes, we didn't see large uplift. We didn't necessarily expect a significant pathology in this group, but we certainly had 2 reporting high-risk suicidal ideation at the baseline. One improved significantly and another left for work reasons, left the study. We had 2 others that reported at different points in the study, reported clinical levels of a PTSD as well. But I actually also, would like to talk to this quote. One participant, this participant shared, came to a session, and actually it was a 6 a.m. session and had been on a late shift previously, and had quite tragically lost a patient unexpectedly, and was dealing with that particular work event, and also dealing with the debrief and the various things, the appropriate processes that are in place for that support. But also she felt that she gained a great deal by coming to the session the next day, and just having a physical and emotional release in session, and preparing herself and being able to get herself in an emotional state where she might then be able to walk into the debrief. So really what we're talking about here is with this particular intervention is that we did see benefits in both types of groups. We also saw, this also deals to people's particular personal preferences, but we did see with a personalised intervention that there was this removal of barriers such as scheduling and accountability, and these kinds of barriers, being able to prioritise the self in a workplace and in a profession that demands so much otherwise. So that greater sense of accountability of having to meet an individual facilitator was quite positive. We had 100% attendance in the yoga arm and only 45% attendance in the group exercise arm.
What are your next steps in terms of whether this could be developed as something systematic for helping health professionals?
The next step is clearly to do a larger and a multi-site trial, with a larger number of facilitators. So applying for funding for a much larger trial is clearly the next step. Seeing also, there are a few of the measurements that that might be improved the next time around, certainly some of the physiological measurements, but also seeing how this might be able to be systemized with multiple facilitators as well. This particular trial, as part of the main trial in my PhD, was run very tightly and with a single facilitator. So being able to replicate this on a broader basis. The facilitator, I was the therapist in this particular trial, but being able to, I was actually certified as a trauma sensitive yoga trained facilitator, which is an additional certification on top of normal training for a yoga facilitator. So starting to get a program where we have that kind of certification of facilitators, that it might be able to be offered, particularly working within the administration and being able to offer the sort of space requirements. It does require a personalised yoga intervention, does require a greater level of privacy. So we did, however, do it in a very small space. It was just a repurposed, unused recovery room, so in a trial clinical space. We were in a mental health building and had to deal very much with the realities of operating in a hospital. So we had 3 duress alarms during the course of the trial, and very much had to deal with the realities of that. But it was, even some of the qualitative data that came out suggested that participants were still able to achieve the level of relaxation and the level of of relief that they were seeking, even in on site. And obviously, being able to provide this on site is the significant advantage, because it's not then a third place that people have to go in order to look after themselves, to maintain, to participate in active coping strategies. The other thing that really came out, Donald, was that we're not talking about a specific intervention that is fit post a specific event happening in a group, with a specific pathology. We're dealing with busy clinicians who are also in training, who are actually experiencing things ongoing. So some of those stresses are stresses of professional occupation. Some of those stresses are particular to medicine, but they were all ongoing, and they happened during the course of the trial, and they also happened, during. So it's very much being able to respond to the needs of the participant on the day, which I think was really the strength of this trial and the great finding out of it.
Have you kept in touch with these participants to know whether or not they've continued themselves to do this, or have they been in touch with you to see whether they could carry us on with your support?
Yes, well, actually, yoga is provided albeit group yoga is provided as a part of the broader MDOK program, of which the group exercise was a component. The personalised program has not continued, but I actually am in contact with many of the participants, some of whom have asked for ongoing support. But that would be rolling out of the broader MDOK program, offering these personalised elements. I'm not proposing, or I wouldn't be proposing, even based on the findings of this study, that personalised interventions were the only offering or the only component, just that they actually have a very powerful place. So there might be, for example, in terms of the feasibility of rollout, there might be a period of time, like a 12-week intervention of this sort, that might be able to be provided on a personalised basis, maintained with some group support subsequently in the case of a broader wellness program. But also then, if people do find themselves in times of great need, they might also be able to come back. One of the benefits of this kind of intervention in terms of adjunctive, particularly trauma-informed support, is that it's able to be very sensitive and trauma-sensitive in delivery, but it's also able to deal with some of the physiological effects. So doesn't necessarily have to be extremely cognitive. It doesn't necessarily have to be a discussion of specifics of things that happen, but it does give people active coping strategies, but also a very empathetic environment that they are able to come to. So there is that sense of therapeutic alliance, and there is that sense of support. So for my future rollout, that what I would like to see tested next is certainly a larger multi-site, where this intervention is provided with potentially a maintenance program, offered in the larger wellness program. So the MDOK program itself is actually was rolled out successfully at the Royal Prince Alfred Hospital. It's been extended to Concord Hospital in the Sydney Local Health District, and is going to a third hospital next year. The trainees, of course, are based at multiple hospitals and do move regionally as well. So many have come through, in fact, at various times in their rotations, and we're able to access the program on that basis anyway. But I would like to see this extend to multiple sites, but also be able to have this sort of offering as part of the support for people that are trying to maintain wellness during training, are trying to maintain wellness during a demanding professional life, but also if and when things happen, have some additional support for coping. Yes, absolutely. And what's quite interesting there is we saw two different types of support in the two different interventions. I was initially imagining that the personalised might have one aspect, and we certainly had a lot of the qualitative data reflected a great sense of social connection in the group training. So it was a chance to do something together that was not a demanding professional environment. You were able to connect on a very even, sort of non-hierarchical kind of environment. They were also able to, because it is very difficult to maintain your social schedule with shift work, with medical training. So it was also an opportunity for people in the same training to actually have some social time, what they felt was social time together, but also check off their exercise. So there was actually quite a positive aspect to the group element. What we did see, and you saw that reflected in the quantitative data, that we saw an uplift in personal achievement on both arms. So we actually felt that the people who were doing some of the yoga and mindfulness certainly felt that they had an improved sense of personal achievement from that intervention. But we also saw that in the group exercise, there was that sense of capacity. It was quite enabling. So they were able to have social connection with the group. It was harder to sustain or keep up the homework outside the group, but it also lost that social connection. And the facilitators are very important here. And on the group exercise arm, they had wonderful facilitators, also quite pro-social, providing that kind of safe, egalitarian environment where people didn't need to feel threatened or embarrassed. We also saw, though, in the comments regarding self-reflection and therapeutic alliance on the yoga arm, that individuals felt that it was the first time in the week that they were able to reflect on their own emotional state, on their own reactions, that they were able to talk to someone in a confidential environment, but without any potential stigma or ramifications. There's just this opportunity to talk freely about how they were feeling and the stress and how they were being affected by the natural stresses of their occupation or of their day, week, whatever happened to be going on. So I think there was an opportunity to connect one-on-one with someone in the yoga or the personalized intervention, but we also saw really great benefit from that social connection. It didn't translate into adherence necessarily. For many, for some it did, but for many it was still just difficult to make it with the demands of work, and particularly if you can't. Whereas if something happened and a participant ended up in ED at the end of a very long day and needed to make contact with the facilitator on the personalised yoga, the session could be rescheduled. On the group fitness arm, of course, that's not possible. So I think those couple of things, social connection and this flexibility that's being able to be afforded, certainly gives some advantages on both sides.
And thinking about engagement, you mentioned that there was a majority of women taking part. Maybe I missed it, but what proportion of those you approached, or how can you say how many were approached and how many actually agreed?
Oh, in terms of the number, so our recruitment occurred during, they were approached by the medical training unit and approached by email and then asked to make contact with the research team, with ourselves. So if we're talking about all junior doctors, we're talking approximately, 130, and we ended up with 20 in this particular trial, and predominantly women, as we suggested. So I think there's also something in that we were also offering something that was of particular appeal to women. which I think is interesting as well. So there is potential here that this was not necessarily strong thematic outcome in the qualitative data, but the recruitment response certainly spoke to that. And my analysis of it was that, in fact, I think it might need to be changes in order to attract more men into the, or to entertain this kind of intervention or offering. But the fact actually that it felt like it was a safe and positive and supportive environment for women, I think is not something to be trivialized. It's actually quite a positive thing.
Dr. Jen Taylor, thank you very much indeed. You can find out more about free live webinars from the FPM by going to our website, thefpm.org.uk.